This is Pop Health Week, streaming live on Healthcare Now Radio. I'm Greg Masters, co-creator and executive producer. Joining me in the virtual studio is my partner co-creator, Fred Goldstein, principal host of the program and president at Accountable Health, LLC. Today, we're diving into something that sits at the intersection of healthcare transparency, employer plan strategy, and ultimately population health impact. Our guest today is Frank Roby, Chairman and CEO of Averify, the company behind healthcare's Fair Price Index. Fred, the mic is yours.
Thanks so much, Greg and Frank. Welcome to Pop Health Week.
Thank you. Delighted to be here. It's nice to see your face in person.
Yeah, it's a pleasure to get you on. So why don't we begin? Give our audience a little sense of your background.
I have a long-standing background in healthcare. Currently we're really building out a healthcare technology platform that is designed to assure plan performance on an optimal level. So not just network optimization, but overall plan performance optimization. But that came as a result of other work in my career that really started off just being a sales rep for an insurance organization, writing small group plans in the early stages of the PPO industry, and then growing into being the regional CEO and an owner in a regional firm where we built our Texas operations and was there for a generation of significant change from open PPOs to tiny HMOs all over the country, reaggregating them, EPOs, narrow networks, the whole ball of wax in the self-funded industry, and that came around really to understanding that there really aren't tools that help you figure out what the right thing is to do. And somebody had to build an analytics platform that was more than analytics in order to be able to actually deliver that value to the end user and the customer. So we're hired by brokers, we're hired by employers directly, by third-party administrators, anybody that's trying to take cost out of the system for the benefit of employers.
And you mentioned plan performance and you talked about network. But when you mean plan performance, what are you really getting at with that?
Well, I'm really talking about getting the most value for the money. Everybody talks about, taking costs out of the system or the lowest total cost of care. And here's the challenge with that. When people talk about the lowest total cost of care, they're generally looking at it through silos. And ironically, those silos were identified by the Journal of the American Medical Association when they did their noteworthy research project a couple of years ago, talking about all the waste in the healthcare system, somewhere between $750 and $950 billion. And if you look at where those dollars lie, other than the pure fraud dollars, it comes down to three categories. How much did you pay? What was the quality of care that you received? Was it appropriate? Was it the right care that you received? And what was the resulting health risk of the member? Was the health of the member improved? And so the irony is, in talking about the best plan performance, is that those three factors operate in the market primarily in silos. Groups take in one side of it. The network is trying to deal with price, and the condition management people are looking at the clinical side of things, and the quality side is something that has generally been, oh yeah, and we do that too. Well, now there's companies that specialize in just the quality component. But the truth is, if you're trying to improve the performance of a plan, you need to look at all three of those in tandem, and the silos don't speak to each other. So Averify's responsibility is to use those data sources as information that's processed through our system so that we can connect the silos and identify where the inconsistencies are and the performance gaps so they can be corrected.
And it's interesting when you said silos and talked about the three that the quality, et cetera. I'm thinking, when you said silos, I'm thinking pharmacy, hospital, provider, physicians and clinicians, home health, and all of those silos. And you really looked at it from the other side, but you pull in those silos themselves within the system to get that data set.
Yeah, that's exactly right. So we just completed a GLP-1 study for a client that was identifying what was the cost of the drugs, and was that patient because they were obese or because they were diabetic or both? And looking at the results of that, did they achieve the objective of weight loss? Did that weight loss translate into a better health risk score? What was the effect of the total cost of care and on the overall efficiency of the plan? Was that care delivered appropriately at the right price? And then how did all that compare to alternative treatments to GLP-1s like bariatric surgery? and in order to be able to do a comparison of really value to the plan. Those answers became incredibly insightful to a company that just spent $20 million adding GLP-1 drugs to their portfolio and looking at the effect on the plan. They knew they were spending more money. The question is, what did they get for that?
Right. And so you were looking at that from a perspective of, did we get the appropriate outcomes for it? Did we pay the right amount for it? Go to the right providers to get that treatment? Appropriate individuals who needed to be treated? In a broad sense, you pull all that together.
Yeah. And another example would just be like MSK, for example. If you're looking at the drug part of it, you're looking at how many scripts did you have for pain management after the procedure took place. This feeds into the quality score of the physician. One physician might have one script for every member, somebody else might have 5 or 6, and that begins to play into the relative quality of the practitioners.
And that brings up a fascinating thing that Greg and I have heard this for decades, which is, the clinician, the physician will say, well, my patients are different.
Yeah.
But you're able to, in essence, clear that up a bit.
Yeah, we are. I mean, I don't know as I would say that there's such a thing as definitive in that area, but what we do is we start with the whole person risk scores, the way that it's described when we work. One of the companies we work with is Converging Health. And that's Dr. Conrad's company that he founded along with the co-founders a few years ago. But, they have a very granular level of evaluating the whole person risk score and what they cost. We also work with Johns Hopkins and their scoring method, which operates differently, but has very similar functionality to it. But in those cases, you're examining the risk score of the individual before you started the care, and then after the care, a period of time after, you can see whether those trend lines there. And then as a plan as a whole, you can look at the macro view of the plan as a whole, and did the risk score of the whole population actually decline or go up? And then with a lot of businesses, as you know, you've got turnover problems. So, you're making investments in improving people's health, but are those people still there to actually show up on the granular level of performance? So it can get complicated. That's why we put so much into the system to help it understand all these nuances to begin with.
Yeah, as you mentioned, it get really complicated. And I love the fact that you talked about the overall population, because as you well know, Al Lewis talks about it all the time, how groups typically just measure the high risk and they move down. We get the high risks better, but we didn't talk about all the low risk and medium risk moving up in the population, thereby creating a population that was less healthy down the road. So you look much more broadly at it. And, I'd like to understand too, do you look at the clinical outcomes and the cost down the road in terms of those patients as you follow those people through, those employees through?
We're not projecting costs down the road. We don't deal with that at all. We are dealing with the costs that happen after the fact. So we essentially look at the lagging indicators, which is what happened in the plan.
Right.
So that's our benchmark that starts by saying this is where you were. And through that, we can determine what's possible as to where the plan can go. And then once we set that in stone as a direction for the plan, this is all done by the customer with their advisors, and we're there to provide the support for all this. We're not usurping anybody's role. We're making that functionality possible for them. In fact, I was on a call today where the comment was, we just want to learn what the right thing is to do for the customer. And because every vendor of every solution is telling you they're the answer, and there's just so many in the marketplace, we're independent. We're not tied to any vendor in any way. So our role is to really identify what will work and then track whether it really happened. So that's the way we respond to that, not by saying, you should only spend $20,000 in the future on this claim, but to really identify, was the health of the member better, and did the claims in total and the efficiency of those claims delivered give you the results that were promised in the performance guarantees.
And you mentioned, obviously these different vendors that are out there offering products within that say, hey, we solve your problem for this, MSK or GLP-1s or whatever. Have you, through this, been able to then identify sort of top ranked vendors, or vendors that you would say, hey, these are ones that people should typically be going to because they're getting better outcomes? Are you ultimately going to do something like that?
I don't see us really in that business. The truth is there's a lot of relationships out there in a lot of different ways. Just to give you an example, we had a vendor situation that was a niche network. I'll just leave it, generically like that. They were solving a particular problem. They came in with a savings prediction We reviewed it through our system. We told the client what the real savings could be, what was actually achievable, because they were using savings averages that included things that were not something they could actually capture. Like if it's an inpatient expense, you're not going to get to the inpatient expenses. You have to deal with outpatient expenses and things where independent solutions have a better chance of working. So we filtered that through, found the right number in there that was actually achievable. And they came up with an answer. We actually helped design the fee into it based on the achievable number. They made a decision. That fee saved them a couple $100,000 in that one example. But my point really is to your question is that you take that same thing and apply it to another one of our customers, and you've got 1/4 of the yield that's going to come from that. And so you can't go in there and say, well, this solution, we save this much here, we'll be able to save that much for you. That's the kind of thing plans do. It's very specific to an employer's experience. So we got to start with that lagging indicators to find out where the problem areas are and then go forward with the strategies that are right for that customer and then filter that out. So we're designing solutions that say this will solve the problem. Now, which vendor do you want to use? And the broker has their own relationship. So they want some support in there. We can provide it, but that's not our business. And we're not paid by anybody to put their product in any of our customers. That's verboten in our world.
And so the underlying situation really is each employer is a unique group. And based on that population and what sort of issues they're dealing with, you'll be able to say, here's where you want to focus. And they may come back and say, well, we'd really like to focus over here. So let's look at this initially or things like that.
Yeah. I mean, I'll give you two examples, two companies that are not clients of mine, so I can say them, as a reference, because it plays right into this. If you look at the profits per employee for Facebook, they've been as high as $1 million per employee. They run over $500,000. That's the profit per employee. You look at a restaurant company like Darden Restaurants that is a publicly held company. Their profit per employee is probably more like $15,000. It's probably less than what a person makes in a year. Their approach to a healthcare strategy is completely different. So some companies are like, look, if we're going to offer healthcare, we need you to be in the game with us on this. And others are like, hey, this is a benefit. It's just a benefit. Whatever you want to do is not going to hurt us financially. We're making too much money in other areas. Do whatever you want. And that's an exaggeration, but not too much of an exaggeration. Many clients just don't have that luxury. And so what they want to do is maintain the best benefits possible. And they're willing to ask their members to accept some responsibility in how they use the plan to do it.
And also, while you were talking about, profits per employee or something, obviously between those two different groups and the industries they're in, their employees are probably completely different in terms of social determinants of health issues and other things that could be impacting their costs.
I mean, this is the tragedy right here of what happened with high deductible health plans and why they were never the solution for anybody other than the management level employees that make a lot of money or are in good health that could build these enormous balances. The HSA balances in America today, the high end balances are approaching $1 million, whereas the average balance is more like $4,000. And in a typical person of modest wages, they might have $1,000 go in and $700 come out in a year. I mean, they're just not getting anybody there, and then they're not getting the care that they need because they can't have co-pays and all this kind of thing. So, you gotta create a solution that actually is for the well-being of your people. And the truth is, you have different people in different industries and different priorities of a company, and all that has to be taken into consideration. That's the beauty of what consulting can do for a company to help them do that. And we're the first analytic system that really has an engagement approach to it, what I would call informing navigation approach to it, that allows them to customize their solution to deliver the best plan within the constraints that they're living with. That's what's so important about that, but that's how we work. That's what we do.
Just tuning in, you're listening to Pop Health Week on Healthcare Now Radio. Today, host Fred Goldstein is joined by Frank Roby, Chairman and CEO of Averify, a company connecting the dots on healthcare pricing transparency, the employer health plan opportunity under CAA, the Consolidated Appropriations Act of 2021, and what fair pricing data means for population health downstream. Stay tuned. More insights are coming up next.
So when you think about these employer groups, obviously some of them have a fair amount of churn in terms of employees coming and going and things. How much does that impact your ability to then be able to work through this system?
Well, it has a tremendous, effect on it. Investing in to keep their health better. It's also going to happen in that people that are high risk, high cost people will be leaving the plan. Either they pass away or they leave the workforce, or something else happens. So there's all kinds of movement around there. So really, one of the main things that we consider when we're looking at things at data is we're able to look at it through any lens that you want to see. You want to focus on a disease. Here's the same data on the disease. You want to look at it for place of service. Here's the same data for the place of service. You want to look at it for provider. Here's the same data by provider. And when I say providers, I mean clinicians as well as facilities. Here's the same data, and looking at it also from size bands. And as I think you would know better than most people, Fred, you've got those high risk patients that do have high costs. Those are active, ongoing situations. Many times those are very complicated comorbidities, or you've got claims that are 100,000, $200,000, $500,000, $1 million claims. We track what we refer to as variability cost. Our whole business is called a variability intelligence system, and that variability is tracked for the variability in price, quality, and risk. And when you get to the prices, we see claims that are $1 million over fair price claims for these shock claim incidences. Well, when those first begin to pop up, when a claim first comes into the system and says this is $100,000 claim, everybody needs to wake up. You want to be able to intercede at that point with the utilization review people to get engaged and say this is not only high cost, but it's high cost relative to what it could be if it's well managed. And then you have to tie back into the risk transfer part of the business, the stop loss part of the business. Our largest customers don't even have stop loss. But if you have a plan that's got $250,000 of stop loss, and you have a $500,000 expense that's $250,000 more than it should be, and you save all that money and the employer paid us for it, well, who wins? The stop loss carrier gets all that money. So you want the stop loss carrier to have a role in making sure that they're contributing to the performance of the plan as much as we are. So we actually talk with customers about that.
Briefly touch on musculoskeletal and why that's such a critical area. You mentioned it earlier for value-based care and things like that.
Well, unless there's a lot of comorbidities with that person, like you've got a diabetic that, you've got a major surgical procedure on, you're dealing with something that tends to be contained. So your complications, you have a managed episode, I guess is what I'm saying, that really can have a pretty, not black and white, but at least dark gray and white, expense filter associated with it. And so therefore it's more measurable. So, bundled services are big on MSK procedures. You're starting to get direct contracting or capitated rates from organizations that do that kind of care, and they're looking to be able to look at those kinds of things. So it's one of those things that you can look at from a budgeting standpoint and get a sense for it. But really, what we see as the value in MSK is that the number of procedures that actually happen is related to what happens before the procedure. And when you are, pre-screening with, if the first thing you do is have the member go straight to a specialist, the specialist goes straight to an MRI, the MRI is pretty much going to go straight to a procedure. But if you have a process where, you have a list of codes, we actually develop these lists of codes, and we don't, impose any of that. That's up to any customer to decide what they want to do. But we can help them with that by saying, if it's one of these codes, it does automatically start, with a clinician like physical therapy, and not with an actual procedure. And then if that doesn't solve it in 3 visits or whatever the rule of thumb you establish in there, then you can have, the MRI for those procedures. And then based on that, then, you might even have a second opinion, and then you'll have a procedure. So you just set things up in ways to do it. And that happens because not every physician has the same motivation, and not every corporate structure of every physician has the same one. So you could have 2 physicians of equal exceptional outcomes, highest quartile outcomes in the market, but the number of procedures that one of them does might be 3 or 4 times another one, just simply based on the fact that that's the first thing they do. So yeah, we have to watch
Absolutely.
that closely because of the process.
Yeah, and I think about my situation with my back issues, where the one surgical group said, "Absolutely, we gotta go in there and fix this," and I went to Mayo. And the guy looked at me and said, "Number one, you don't want me to do this to your back because this is what it would look like. And number two, I'd probably get sued for malpractice if I did that."
Yeah.
And so yeah, I didn't get the surgery, but they were all ready to go. It's just fascinating to watch this stuff. So let's touch on a little bit. One of the areas that had come up in prior discussions was this whole area of voluntary benefits. And you
Yeah.
had some unique thoughts on that.
Well, I've been in the business in a way that voluntary benefits were a real crucial role in any company's planning. So I see the value of voluntary benefits. The challenge with voluntary benefits is not the value of it, but the way that they have emerged in the marketplace. So in other words, nobody's going to call on an individual to buy individual life insurance if they're, a modestly paid worker. So getting that through your company in a product that is transferable or portable or however you want to refer to convertible, has real value in there. But when you start getting into voluntary products on the medical side of things, mini med plans, basic medical programs, many times those come into play as a result of other decisions that have been made that are not efficient in the plan itself, like the high deductible plans that we were talking about earlier. If you've got a $3,000 deductible and you have no copay structure that's available to you because you have that with an HSA in your plan, and you have a family and everybody needs to go to the doctor, there's somebody's going to need an urgent care center or whatever it is, you want a plan that is going to be able to pay those costs so that you can cover the first 10 visits or whatever it might be. It's a limited benefit plan. And it's not that those plans don't have value, but you're really stacking when you look at the tolerable loss ratio inside of those programs, maybe it's 50%, 60%, 70 if you're super lucky, on that. But they're adding a layer of expense that an alternative design to the core program could have addressed that didn't address it. And so many times you're offering products that generate additional commissions when really the original product, could have been designed better. And so what you're looking for is ways to really prove out, are you getting the value from everything that you do? And that's why voluntary products need to be considered, but considered with at least one eyebrow raised, if not both.
Just at the beginning, really take a look at it and understand, hey, you're paying X for that product over there. But if you applied that to your core benefits over here, you'd have better results.
Yeah. So if you go to an employee and say, we're going to reduce your contribution to your healthcare plan because we're putting this new high deductible program in, and now we're taking your cost down by $50 a month, and then we're going to offer this voluntary plan. So if you want that coverage, you can buy it for $70 a month. Well, it's like, let's see, 50 more than 70 or less than 70. It seems like it's almost silly at this point, but that's the kind of stuff that happens if you're not careful.
So when companies implement your product, what do you typically see are there savings that come out of this? You're showing lower overall costs, better outcomes, obviously reduce the risk of the population. Is that fairly typical?
Well, yes, but there's a sequence of things that take place. So the first thing is the report card. We actually do. I don't think I would literally call it an audit, but from a practical speaking standpoint, we're providing a financial performance audit of the plan. Did you deliver the best possible care at the best possible price with the best possible outcome to your people? That's the report card that comes out of our system on the front end. So you know where you stand right there. So there's no savings involved in that. There's just an awareness of that.
Sure.
Increasingly with Consolidated Appropriations Act and transparency rules and the risk of saying, oh, now that you know about pricing and access to that information, now we need to hold you accountable over here for that value. Because all of those things are happening in the marketplace, every public company at least should have a report card that says this is what you're actually achieving and these are the areas where you can improve on. That would be an ideal scenario for the market. But just because that is in place doesn't mean that you've actually saved any money. So now what you have to do is identify, here's how much money was left on the table. Quick example of that is a company that had a bundled procedure program in place. They were stating what the savings was to the plan. We took a look at it from our standpoint and said, well, yes, actually, they did save you money. but they actually didn't quite save you what they said they saved you because there were some assumptions that went into that, but it was a very effective program. So congratulations there, except there's one problem on that. They missed 80% of the opportunities to save money, and had the savings they applied to the 20% they did applied to the 80%, it would have been another $5 million. And so you look at that and go, well, wait a minute, what happened? Well, that's not the vendor's fault. Some of it may be through follow-up or whatever, but typically that's a plan design issue. That's an incentive issue. So, but you need ammunition internally in a company to be able to go back and say, look, we found out we left this much money on the table. If you want this, we need to do this to the plan design because we're going to give up $500,000 in waiving deductibles, et cetera, but we're going to save another 3 million, 5 million, whatever those numbers are. So being able to identify that, provide that safety valve that sees that, we actually create a savings calculator that sorts through all that, including measuring the likelihood that somebody's going to have a better deal. Because inside every network are great values and terrible values, and they all come to you with 60% discount. So you never know which is which, but we can sort through that and navigate around that.
Well, it's really fantastic. I like the way you talked about that because it just sounded like population health. You got to start with the data. Here's where we're at. Here's what we've got. And then now let's figure out where the issues are and then what we're going to do about it and how we're going to improve that population.
And I love that, Fred, because really ideal place for a company that is employee-centric to start is what is the health of your population and is that health acceptable to you? What do you want for them? Not do to them, but what do you want for them? And what does it take to get there? Now, how do we do that without blowing the budget of the plan? And so you look for how the plan is used. I mean, it all can coexist beautifully. All three of those silos about price, quality, and risk can coexist beautifully if you get them to play well with each other. And to do that, you've got to be able to connect them.
Well, that's a fantastic way to finish the show, Frank. I really want to thank you for coming on.
You're very kind to have offered me the opportunity, Fred. I look forward to following your future podcasts, and thank you for all the work you're doing.
It's my pleasure. And back to you, Greg.
And that's a wrap for today's episode of Pop Health Week. Thanks to Frank Roby for a clarifying, grounded conversation on the role of pricing, transparency, and population health. And to our global audience for tuning in and doing the heavy lifting of moving healthcare upstream. Today, we connected a deceptively simple insight. When employers can see what healthcare actually costs, independently benchmarked, not filtered through a network's discount math, they make better decisions. If Pop Health Week brings value to your work, please support the show. Do subscribe, share this episode, and leave a review on your favorite podcast platform. On behalf of Fred Goldstein, myself, Greg Masters, and the entire community at Healthcare Now Radio, thanks for listening. Catch you next time on Pop Health Week.